This is San Diego's Central County Parkinson's Support Group virtual speaker series. And our topic this evening is the importance of having a urologist on your team. Our speaker this evening, whom we're very fortunate to have, is Dr. Santiago Lastra. Dr. Santiago Lastra is a urologist who specializes in diagnosing and treating a wide range of urogenital conditions in both men and women, including those caused by neurogenic disorders such as Parkinson's. She's an associate professor in UCSD's Department of Urology and instructs medical students, residents, and fellows at UCSD's School of Medicine. She earned her medical degree from the University of Puerto Rico School of Medicine, where she graduated magna cum laude. She completed her fellowship at the University of Michigan Medical School and her residency in urology at Harvard Medical School, Massachusetts General Hospital, where she was selected for her clinical and leadership skills to serve as chief resident. And then following her residency, she served as clinical instructor in surgery in the Department of Urology at Harvard Medical School. Dr. Santiago Lastra was born in Puerto Rico, is fluent in Spanish, English, and French, and when not working, enjoys traveling and writing nonfiction. So without further ado, I'd like to turn the evening over to Dr. Santiago Lastra.
Thank you so much. Thank you so much. I am very excited to speak with all of you. This is an area that's very near and dear to my heart. There is actually a lot of Parkinson's disease in my family. And I grew up with a grandfather and an uncle who both had Parkinson's disease. And it can be very challenging to handle all of the ways in which Parkinson's impacts your life and the life of your caregivers. And so my role as a urologist is first and foremost to provide you options and to listen to what might be important to you and to what I anticipate might be important to you down the line. And so today I have a presentation that is focused on you getting to know sort of a day in the life of a urologist as they evaluate patients like all of you, and to put some thoughts in your mind about what the urologist can offer you as far as options, so that you are better able to advocate for yourself, because that's really important when you have Parkinson's disease. Urologists and many physicians, we will give as many options as we can, but ultimately it's that relationship between the patient and the doctor that allows us to really understand what's going to be important for you and to your family and to your quality of life. That's the most important thing. So I'll go over some of my thoughts about Parkinson's, how it affects the bladder and the urinary system and the genitourinary system. And then I hope that you have questions along the way. Feel free to interrupt if you want to wait till the end, but I look forward to also learning from you and your perspectives, especially if I say something that you want to enhance. So without further ado, let's get started. When patients are living with Parkinson's disease, there's a burden of issues that can arise from it. And I want to highlight some of the common issues that make patients reach out to the urologist. One of the common ones, urinary urgency, bothers me. I find myself unable to get to the toilet in time with that sensation of urinary urgency attacks my bladder. I get up way too much at night. It's a huge problem for me because it's not just that it's interfering with my sleep, but it's harder and harder for me to get to the toilet. I'm worried that one day I'm going to fall and not be able to get up or hurt myself. My sexual function has changed. I have pain when I have intercourse, or I can't get erections the way that I used to, and I feel like it's related to my medications. I have no desire to have intercourse because I'm depressed. It's taking way too long to empty my bladder. I feel like I'm in the toilet forever and ever, straining to empty. I'm getting bladder infections. I was hospitalized with a bladder infection, and that set me back for months. Or I now wear pads and diapers. I smell. I'm just, really depressed, and I can't leave the house because I'm wet all the time. These are some common things that I'll see when patients with neurogenic disorders come to my clinic, and that includes patients with Parkinson's. And there are many more complaints, but these are some common ones. The urinary symptoms can be really problematic in Parkinson's disease, and Parkinson's disease itself can be a direct cause of those urinary changes. And I'm going to try to go over with you how our brain and bladder are connected and how the bladder stores and empties itself, so you understand the relationship there. But it's really important to also remember that aging and other medical conditions like an enlarged prostate or pelvic floor disorders can also contribute to these urinary symptoms. And sometimes it's like a constellation of symptoms. It's not just that the Parkinson's disease is worsening, it's also that patients are getting older. Women are entering menopause, and estrogen is very important to the bladder. Or men are entering andropause because testosterone is very important to the bladder and to the prostate. Even so, these symptoms that are very common in all humans as they get older are worse for patients with Parkinson's disease, and that's the reality. So this is a little graph of the kidneys up here and then the bladder below. And I drew little hearts because I love the bladder. And I also drew hearts because, we all know how the heart functions. We know the bladder fills with blood and then pumps the blood, fills with blood, then pumps the blood. And the bladder is similar. The bladder fills with urine and remains filled with urine or filling with urine throughout most of the day. And then at certain important periods during the day, when you choose to do so, your bladder will act like a pump and it'll squeeze and pump the urine out. And so when we're babies, our bladder fills and empties reflexively, which means that it occurs with our brain and spinal cord controlling that without the baby really paying any attention or deciding when to urinate. And our parents, as we get older, maybe we're toddlers, maybe we're young kids, as our brain matures, our parents can teach us how to urinate in socially appropriate situations. So there's some brain control there. So let's bring in a little model of the brain. And here I'm just stating that the urinary bladder has two functions and they are both controlled by your brain. So the storage is just like a sac that's just filling with urine passively throughout the day. And then the emptying function, where the muscle of the bladder will squeeze just like the heart squeezes and empty itself. And so you can see a brain here. Perhaps the people that are on the phone can't see, but I'm using my cursor to point to certain key areas of the brain. So you guys probably all already know that the issue with Parkinson's disease is that loss of function of the dopaminergic neurons in an area of the brain or the midbrain called the substantia nigra. And we could talk about hours, what happens there. But what you might not know, or you might know because Parkinson's patients are extremely well-educated individuals, but what you might not know is that the pontine micturition center, which is the command center that helps the bladder switch from storage to emptying, is also found in this primitive brain here that's close to the midbrain. So the pons and the midbrain and the thalamus, they're all part of that reptile brain that works without us having conscious control of it. And then these squiggly worm-like areas is the cerebral cortex, and the prefrontal cortex over here in the front, that's the area that starts to get bigger. That's why little kids have that big head. So that area there starts to mature, and that's what helps us make those conscious decisions and potty train and decide when we're going to go to the toilet. So all those nerve fibers then come down and help control our reptilian brain into whether it's going to store urine or whether it's socially appropriate to go and empty. Because those fibers are all passing through the area, that substantia nigra, when Parkinson's hits or there's an onset of Parkinson's disease, you can see how, in a very cruel way, the disease takes away our ability to remain potty trained. And so our brain still functions quite the same. We still are very bothered by the incontinence and by the infections or by the straining to empty, but it's increasingly hard to do anything about it. And so that brings about problems. And so storage problems that you can see, so it's an issue with the bladder not holding on to its urine the way that it's supposed to, like a little sac under low pressure until we want it to empty. Our problems with urinating at night, problem with urinary urgency, that really got a pee sensation, loss of bladder control, so wetness or leaking or accidents needing to use diapers. Increased frequency of urination, meaning you're going, instead of going every 3 to 4 hours or 4 to 6 hours, which is what socially in our modern world is typically what's considered socially acceptable amount of time to go to the toilet. We're going every 20 minutes, 30 minutes, 90 minutes, or we have to wear pads or diapers. And then the urinary tract infections. Urinary tract infections are not a symptom, but urinary tract infections are a really common chief complaint of patients with Parkinson's, and they are a sign that something is happening with the bladder that's not normal. But at the same time, I include it here because for some patients, the frequency of urination, the urgency, the nighttime urination, none of that is really happening or bothersome, but they're still getting infections. And so it was important for me in this talk to really include infections as one of those urinary symptoms, because not everybody that gets infections in Parkinson's disease will necessarily have all these bothersome symptoms, but yet there may be something going on with the bladder. And so there's also emptying problems, incomplete emptying, weak stream, intermittent stopping and starting of the urine, straining to urinate, and then also infections, because they can arise from problems with either. Most patients with Parkinson's disease will complain first about storage symptoms, so the problems with bladder control. But there are a few, especially men, that will also have emptying problems, and that can mean that there are some prostate issues as well. This is a really this was a really great learning opportunity for me, because this was a survey that the Parkinson Alliance conducted in patients that had Parkinson's disease, looking at their quality of life. And they asked people what symptoms were adversely impacting their quality of life. And as you can see, most of the patients, about 78% of the patients, so 3/4, would say that urinary or bladder symptoms affect their quality of life in at least a little bit. And there's some that say quite a bit and somewhat. So these symptoms are causing a lot of issues for most of the patients. And there's a small minority of patients whose quality of life is extremely debilitated as a result of urinary symptoms. And that's why I think it's important to have a conversation with groups like yours, because it not only allows you to learn about urologists and how we can help, but it also helps us learn about what things are important to you and what we could do better to help you cope and have the best quality of life that you can with your disease. So urinary symptoms take an enormous toll on quality of life. The bladder is very complicated. The problems with the bladder are not only bothersome in and of themselves, they can also increase risk for falling. They can increase caregiver strain because it becomes a lot harder to deliver that care. It can decrease your desire to socialize and leave the house, because if you need to know where every bathroom is and place where you're going to visit, may, take away your desire to visit those locations. And it can increase the need for care in a nursing facility, which is also, a problem as well for patients with Parkinson's. But one of the things that I notice a lot when patients come to see me is, they want options that will allow them to improve their quality of life. So I'm just looking at the chat right now. Okay, perfect. I'm going to look at those later on in the day, but I love it. As you think of questions, definitely write them down there, and I will try to get to all of them at the end. One big thing is maintaining quality of life, and I want to say I'm there with you. I think maintaining quality of life is huge, and sometimes it can be so hard to feel whether the urologist is listening to you or whether the doctor cares. We're all so rushed. Sometimes visits are so short, and there are so many issues, right, to unpack and to figure out. And that's why I think long-term relationships with a team of the urologist, his or her nurses, your family can be really useful, so that slowly over time, as we go on the journey together, we can start to make some changes in your health and in your urinary quality of life. So what is that? What does that mean? What is a visit to your friendly neighborhood urologist? Because urologists have been known to be one of the more friendly specialties, although patients are never happy to come and see us. We tend to be a pretty happy bunch. So one of the first things we'll want to know is when the problems began, and we're going to start to think about, how that may or may not be associated with the progression of your Parkinson's or change in medications, etc. If you come to UCSD, much to your chagrin, there may be a lot of paperwork, but I am here to tell you that questionnaires are not the devil. They really help us. There are a lot of validated questionnaires in urology, and they just give us a whole snapshot of not just your bladder health, but your overall health, your frailty, your sexual function, and then knowing the rest of your history and additional medical problems is very important, because the medical record doesn't always do a great job of keeping things up to date, and a lot of things are so standardized that everything may not apply to you. The physical examination, when you come in to see us, just so you understand kind of where our thoughts are, the physical exam, when we see you, we're looking to see, did the patient walk into their appointment? Did the patient come in a wheelchair? Do they have a supportive family? Is their caregiver with them, or did they come by themselves? Did they come from a nursing facility? What's their functional status? One thing you may think, this doctor just talked to me and didn't do, a full physical exam. There was no stethoscope, what's going on? Sometimes just from looking at how easily you get up from your wheelchair or you get up from a chair to sit down on the examining table tells us a lot about your health. That's something called a timed up and go test. And what we're doing there when we're watching the patient get up and sit on the examining table is how long does it take the patient to do that? Because the longer it takes for patients to perform that task, the more frail they are. And we need to consider frailty as a very important factor when we're deciding on what treatment options are going to be ideal for that patient. Evaluating the blood pressure or looking at the vital signs, extremely important for us as well, because it tells us whether you're a candidate for certain medications. And then the much, no one's cup of tea, the pelvic examination or the digital rectal examination. Often, I will usually do a rectal examination, not in everyone, it's not necessary for everybody, but when I do it, it's usually at that initial visit and mostly in men and women to assess two things. I want to feel the prostate, that's really important, and that's what we all know about. There's a bunch of doctor jokes about urologists and rectal exams. But the other important thing is assessing your bowels. Your sphincter tone, are you constipated? Is there a lot of stool backed up there? Because I tell patients this every day. The bladder and the bowels are two wings on the same bird. And if you're constipated or you have difficulty moving your bowels, which is part and parcel with Parkinson's, it's very common, that will affect your bladder function, guaranteed. You may not recognize it to be so, but it is so. They're anatomically very close to each other. They depend on the same nerves to function, and if one is affected, the other will be as well. And then the baseline neurological evaluation is definitely not as sophisticated as your neurologist, and you probably know about the neurologic examination than I do at this point. But we do look at cognitive function, memory, ability to converse, and then motor ability, because some treatments will depend on that as well. Additional diagnostic tests. One diagnostic test that I've found is extremely useful, and I love to do it in patients who have a lot of bladder symptoms, is the bladder diary. So bladder diary, you may come to see a urologist and talk to them for the entire visit about your bladder symptoms, and at the end they may tell you, you know what, I want you to do a bladder diary and bring it back to me. And you may think, but I just spent half an hour explaining to this person all of the symptoms that I have, and I know my body, I know my symptoms. The bladder diary is still really valuable. It tells us how much your fluid intake has been during the day. It tells us how frequently you're urinating. It gives us the volumes. And so if we look at this lovely patient who filled out this bladder diary for me, you can see their intake of fluids and then the ounces that they're voiding. And so for this person, I was really able to pinpoint what the issue was. They were drinking lots of coffee in the morning, and then in the evening, 12 ounces of beer, 12 ounces of beer, 12 ounces of beer, 12 ounces of beer, 12 ounces of beer. So they had urinary frequency, and clearly that was highlighted not by the previous history, but merely by the diary. And despite that, I was also able to see, okay, maybe they do need to cut down on the beer consumption, but look at these ounces, 4 ounces, 3 ounces, 4 ounces. This person's bladder holds very little. So even though I expect them to make more urine because of the fluid consumption, their bladder's not holding as much as it used to. And that is very common in patients who have urgency and frequency. And we call that overactive bladder. So as a Parkinson's patient, that may be your predominant symptom, that you just feel like you're going to the toilet so much and your bladder just doesn't hold what it used to. And that is very common, again, because that switchboard, the pontine micturition center, no longer responds to those commands coming from that frontal lobe. And the switchboard just shuts on and off independently. And sometimes we can retrain it, even if you have Parkinson's, but sometimes other treatments are necessary. The bladder diary gives us information about a few other things as well. A uroflow meter is when we have patients urinate into this big funnel that measures how quickly you urinate. That gives us a lot of information as well. And then a post-void residual urine volume is something you may get frequently in the urologist's office as well. And basically is a small ultrasound or catheterization that occurs where we measure after you've urinated how much urine is left behind in the bladder. And every patient's different, but typically if your bladder has a residual urine volume of around 200 milliliters, that that is considered incomplete bladder emptying, and we periodically will assess that, especially if you have already issues with bladder emptying or you're on a medication that has that as a side effect. Really important for patients as well as if there's something that I want you all to take away from today is to understand the urologist's core values during the visit and what our goals are when we talk to you. Number one, and very important, is to determine what's important to your quality of life. So there will be a lot of things that are going through our head about optimizing your urinary system. And some of those things may involve invasive procedures, and that may not be for you what you want for your quality of life, because you know your body. You may know that if you that the last time you went for a surgery or the last time that you were hospitalized, it really set you back for a long, long time. And so that conversation is when we get to know, what does this patient want? Because we can, most of the time, give you several options of what to do, some that are invasive and some that are not. So that's the first part, determining what's important to you, what you want to accomplish from this visit. In addition, we, as urologists, we own the entire genitourinary system. And so for us, it's going to be really important to make sure your complete urinary system, from the kidneys, the ureters, the bladder, the penis, the vagina, the testicles, to make sure that whole genitourinary system is healthy. And so we will also, at some point, ask questions about sexual health. We may administer a questionnaire, or we may ask you outright. However, that won't always happen in the first visit. I wish it did, because sexual health problems in particular are so underreported in Parkinson's patients. And it's because the doctor doesn't ask you, and patients also don't talk about it. And sometimes we focus so much on bladder health, the prostate, the kidneys, that we forget that that is also a huge risk factor for depression. It really affects quality of life. And guess what? Urologists can help with that as well. So my apologies if that doesn't occur at your initial visit, but at some point that is something that is important for us to talk about. And in our program, we actually have a really lovely physician assistant who we have made sure is educated to help patients in that way. I'm so hyper-focused sometimes on the bladder and research in the bladder, surgeries for the bladder, that I don't always stay up to date with sexual health. And so I've just made sure I have a partner that's always going to provide that for my patients. And I also have an MD colleague who I will send more complex referrals to as well. And I make a point to have that available for patients with neurogenic bladder, because I think it is really important. And then lastly, we want patients to be continent. We don't want patients to be in diapers or pads. And sometimes we can't get patients to be completely dry, but that should be the goal. The goal should be to get the patient as close to that as possible. What that means is it may mean that in our mind, we're thinking we want to do additional testing, but that may not be in line with what you want for yourself. So that's where we have a conversation about what we recommend and what that will entail. So that conversation can take place, and we may recommend different things. We may recommend a kidney ultrasound, because we may feel that the way that your bladder functions puts you at risk for stones or dilation of the kidneys. We may recommend blood work. We may recommend a prostate serum antigen, or we may recommend testing of kidney function, or we may check testosterone levels if there's a concern about testosterone levels. We may recommend what's called a urodynamic study. A urodynamic study is the considered the gold standard evaluation of bladder function. In this study, and nobody likes this study, we have to put a small catheter through the penis or through the urethra into the bladder, and then we put another small catheter into the vagina or into the rectum. And we fill the bladder slowly to see how the bladder stores urine, and then we have the patient empty, and you're sitting on like a little throne that's shaped like a toilet, and you urinate, and we measure all those pressures, and it gives us a great snapshot of your bladder, how it's functioning, how the pressures are. And sometimes with really tricky situations where patients have symptoms that are very, very difficult to treat, it can really help guide our treatment options for that patient. Many patients worry about catheters, and rightly so. Catheters are associated with infections, and we want to avoid them as much as we can, but sometimes a catheter will be the option that's offered, either because we need it to diagnose, we need to do it for the urodynamic study, or because your bladder's just not emptying, and unfortunately that in order to get you to where you want to be with your quality of life, that may be one of the options that's discussed. But you're in control. Doctors can only make recommendations, and sometimes I've had patients tell me, look, I know I can't empty my bladder. I know that this puts me at risk for infections, but I do not want to catheterize, and I won't. And that's just how I want to live my life. And we respect that, and we'll work with you within the lines of what makes you comfortable. Sometimes patients will realize over time that it is actually better to have the small catheter or try the treatment, but everybody at Parkinson's manifests so differently in each person that we kind of have to let people arrive at their decision at what works for them in their own time, because there is no standard guideline of you need to try this, you need to try this, you need to try this, at least not for urological conditions or bladder conditions in Parkinson's. Even the patients who have mild symptoms or the patient has really severe symptoms, every single one of those people can improve the health of their bladder. You will not cure Parkinson's with these interventions, but you can make it better. One commonly recommended thing that I will recommend to everybody on this Zoom call, including myself, is timed voiding. And so timed voiding basically puts your bladder on a schedule, and the bladder really responds to that. So maybe you're the kind of Parkinson's patient where the bladder doesn't tell you it has to go until it's the absolute last minute, and you either run to the toilet, which many of us can't do, or you have an accident. And so timed voiding anticipates that. The ideal time for timed voiding is about every 3 to 4 hours on the clock. So say you get up at 6 in the morning, you're going to get up in the morning, go at 6. You're going to go again at 9. You're going to go again at noon. You're going to go again at 3, 6, 9, and so on. And over time, your bladder will get used to it. There's a phenomenon actually called latchkey incontinence, so that you realize that your bladder is paying attention. And what that means is patients will say, oh my God, I'm fine, I have no symptoms, but then when I arrive to my house and I am turning the key to my house and I open the door, then I have to run to the toilet, because if I don't do that, I will have an accident. And I'm fine for the rest of the day. And that is that brain-bladder connection. The bladder knows that your behavior is that you get home and you sit on the toilet. And so it's ready to go, and it's programmed. And so you can retrain your bladder to a degree. The earlier you do it, the better it is. And guess what? Pelvic floor physical therapy can be extremely useful for that. I am a huge advocate of pelvic floor physical therapy. Right now with coronavirus, it is very difficult. Patients don't feel comfortable going to a pelvic floor physical therapist necessarily, but it can be incredibly useful. And some of them will do home visits. Fluid management can be useful. Again, that bladder diary really helps us to figure that out. And we have nurses and nurse practitioners who will go over your bladder diary with you, which is really nice. And the physical therapists do as well. Sometimes an external drainage system, not a catheter, just something external, can work really well. Probiotics, D-mannose, healthy diet, all of these things can make a difference. This slide is a bit busy. One important thing that I highlight here is the multi-system atrophy and Parkinson's disease, because they really are two different disorders, and there may be patients with MSA in this support group, there may not be. But sometimes if you do carry a diagnosis of MSA, it may be really important for us to distinguish that with your neurologist, because patients with MSA are going to need a little bit more help on every part of the way to really improve that quality of life. Another thing that can be incredibly useful, because again, Parkinson's patients, if they're older, may also have menopause. And so vaginal estrogen can be really useful. Different formulations exist. There are creams, there are vaginal suppositories, there are rings, but they can really help for recurrent UTIs. They can help for vaginal symptoms, pain with intercourse, and they can help with urinary urgency. So for women with Parkinson's who are suffering from these issues, vaginal estrogen can be something really simple to use, and it does not carry with it the same risks as the estrogen by mouth. It is very safe to use vaginally, and in fact, we often will prescribe the low-dose formulations for women who have had breast cancer. So we strongly advocate for that in select patients who may benefit from it. Another medication that's commonly prescribed is the anticholinergic medication, ditropan, tolterodine, all of these different types of medications. One thing that I want to highlight, because it's really important, especially in the Parkinson's population, is that these medications, first of all, they have a lot of side effects, and there can be a risk of polypharmacy, and some patients may not tolerate it. So often, what I will try to do, if a medication to help with bladder control is indicated, I'll try to steer patients towards mirabegron, and sometimes we have to do these really prolonged processes for authorization from insurance to get the mirabegron covered, because it is very expensive, but it is a great way to go with a lower side effect profile. But we have to check your blood pressure while you're on that medication. That's why those vital signs obtained initially in the visit were so helpful. In addition, men may have some prostatic enlargement, and this is a nice picture because it highlights for you what's going on when we tell you your prostate's enlarged. So you'd see a normal prostate on the left. You see that channel of the urethra. This is the bladder. As it squeezes, the urine comes out through the channel, no problem. When the prostate enlarges, then you can see this channel is much narrower, and it can become problematic for the bladder to empty, and it starts to thicken. And then to add insult to injury, the bladder in Parkinson's disease may be weaker, and the pelvic floor, which has to relax in order for the bladder to squeeze and empty, does not empty as quickly. It's in that rigidity, and that prevents you from moving as quickly as you want, or having the dexterity that you want. It can also prevent your pelvic floor from relaxing when you need it to. And so that all of that combined can lead to a lot of symptoms for men as they get older as well. So for men, very common that we'll recommend alpha blockers to help you empty, and 5-alpha reductase inhibitors to shrink the prostate. And these medications work really well, and patients can be on them for years with good results. Sometimes over time, they're just not sufficient, and so we have to have other options. And so if you have a refractory overactive bladder, and you're you've tried medications, you've tried physical therapy, you've tried the bladder training, and there are still a lot of issues with nighttime urination, urgency frequency, needing to use pads or diapers, then urologists do have other options. One is sacral neuromodulation, which is very similar and also made by Medtronic, who offers you the deep brain stimulation. And it is an electrical wire that's placed at the S3 sacral nerve root. You can see it right here. And during the test period, it's connected to an external battery. And then patients will use it for a period of time to see whether it helps with their urinary symptoms. And if it does, we put a very small MRI compatible generator right below their pelvic brim, right as your buttocks start to become a little more fatty. And it's a good option for some patients, especially the younger Parkinson's patient, because it doesn't make it harder for you to empty the bladder, which is great. It can help with the bowel control as well. With good reprogramming, it continues to be effective over time. And so again, it's not going to be for everybody, but this is another one of those options that may exist for patients with Parkinson's that your urologist may talk to you. And that's why we look at frailty as a measure, because if you are already very, very frail, some of these treatments may not be for you. We're not going to go over this as much just for the sake of time, but I'm happy to answer questions about it later. There's also Botox injections, which many of my patients with Parkinson's will get to help them better control the urinary incontinence, especially for the patients where it's incredibly bothersome. And Botox is used throughout the body. It's used cosmetically in the skin to prevent wrinkles. It's used for contractures. It's used for spasms. And we use it in the bladder to reduce that very thing, bladder spasms. And so it helps patients have better bladder control. And the way you can think about it is it just helps your bladder hold on to more urine if it needs to. And it helps also to prevent nighttime urination. Some of the risks are that we have to do the injection with a scope that goes through the urethra or through the penis into the bladder and inject it with a small needle. So there is a risk of bladder infection until we have to check a urine sample beforehand and maybe give you an antibiotic the day of if this is how we're doing it, and it does wear off. So over time, you'll need to get several injections to continue to have the same result. Another popular treatment for urgency symptoms and frequency symptoms is tibial nerve stimulation. Tibial nerve stimulation is very low risk, and it is the same rationale as the nerve stimulation on the sacral nerve that I showed you earlier. What this does is we insert a small acupuncture needle that you can't even see on the slide because it's so small, but the tibial nerve and the nerves to the bladder join up in the same nerve root on its way up to the spinal cord and up towards the brain. And so if we stimulate the tibial nerve right there on the ankle, like on that picture that you can see, those signals go up and travel to the nerve to the bladder, and they tell the bladder basically to calm down. And so it helps control the urgency, the frequency, the nocturia symptoms. All of these treatments, the Botox, the sacral nerve stimulation, the tibial nerve stimulation, they're not a cure. You can expect probably about a 50% improvement in your symptoms. So basically, if you're getting up 5 times a night, for example, perhaps you can expect that to reduce your symptoms by 50%. Maybe you're only getting up 2 to 3 times. So it'll still require some additional treatments, or if your symptoms are really severe, it may not be worth it to you to pursue these strategies. The PTNS, as we call it, is very safe and effective. It doesn't require any implants or surgery, so it's very safe for patients who may be risk averse about going to the operating room. It can be up to 80% effective, but all of these trials were not done in Parkinson's disease patients. So all of these treatments, if your doctor talks to you about success rates, those success rates were not necessarily tested out in the Parkinson's disease population. So one question that I would encourage you to ask any urologist that's treating you or offering you treatment is what their success has been in patients who have Parkinson's specifically, or who have a Parkinson's level of progression like yours, because it may not be that 60 to 80%. It may be lower. But the nice thing about PTNS is that it has no adverse effects. Now with COVID, you have to come in to get the treatments once a week for 12 weeks. And that may not be ideal when we're trying social distancing. But in a few years, there will be a home option that gets implanted like a pellet under the skin. So that may be great. So that this significant time commitment that I talk about may be less frequent. Once you complete those 12 weeks of stimulation, you actually only have to come in once a month for a touch-up. So it's not as bad after those initial 12 weeks, but it's still significant time commitment. For men who have persistent difficulty emptying, we can do what many of my male patients call the Roto-Rooter, which is essentially opening up that channel for the prostate to allow them to empty a lot better. And it's very viable and has good success. This has been tested in men with Parkinson's disease. And I think for functional, motivated men who are good surgical candidates and have Parkinson's disease and prostatic obstruction, this is a great option. And I'm going to show you a little video. I hope I don't make you guys squeamish. It's not that gross, but this is a transurethral resection of the prostate. So this is an electrical loop, and this is us shaving out. So see, it's literally we're scraping at the prostate and opening up that channel so that it's easier for the patient to empty. And so we do that all the way around that prostatic urethra until the channel is wide open. And then we place a catheter for a few days to a week. The recovery period is about 6 weeks, and the results are pretty good, but you have to be motivated to go through the procedure. So again, not for everybody. Let's go to the next slide. Sometimes an indwelling catheter is the best option for many patients. And some patients will come to see me and they already have an indwelling catheter in their urethra. And I'll try to talk to them a little bit about what that can entail, because having an indwelling catheter for a long time in the penis can cause an erosion. So basically the skin will break down. Same thing in the female urethra. So often what we'll do is we'll talk to patients about a suprapubic catheter, and that's what this patient has. So it's the same Foley catheter that patients may have going into their bladder, but it's going in directly through the skin into the bladder. It's a very quick outpatient procedure that we do. When patients reach more of an end line in their Parkinson's symptoms, it can be a lifesaver, and it can decrease the incontinence episodes. It can help them get a good night's sleep. And sometimes we'll even combine it with Botox to the bladder, so there's no concern there. Again, sometimes the catheters really are the best option. Lastly, problems with sexual function, again, can occur in both men and women, and they are underreported in Parkinson's disease, and we can help. Again, we talked a little bit about this earlier: decreased libido, problems with erections, difficulty reaching orgasm, painful intercourse, vaginal lubrication issues. All of this is amenable to medication therapy, and actually the medications for erectile function and the medications for vaginal lubrication, or vaginal estrogen or vaginal androgen, they have fewer side effects than many of the medications that are being used to treat overactive bladder or to treat Parkinson's disease in particular. So if this is something that has been very detrimental to your quality of life, even if you feel like the visit has gone on for long, just mention it to the doctor and just say, hey, I would like a visit to discuss this. And now with COVID, telemedicine appointments have been a lot more common, and they're getting reimbursed. And this is a really easy thing that you can discuss during a telemedicine visit with a provider. It doesn't even have to be a urologist. It can even be your primary care physician, but it can really help with quality of life as well. I wanted to take a minute to show you my team that delivers urology care along with me. It really takes a village. It's very, very difficult to have a practice where you treat a lot of patients with neurogenic bladder. I don't just see patients with Parkinson's. I see patients with multiple sclerosis, spinal cord injury. I see young adults with spina bifida. And so, these patients have a lot of concerns. They have a lot of issues that we need to help them with. And so we have a great team. Sue, my scheduler, coordinates all my studies, all of my tests and surgeries. Rachel is a lovely physician assistant who will help patients with their bladder control disorders, neurogenic bladder disorders, their sexual function disorders, kidney stone issues. And then my nurse and my partner, Dr. Albo. Dr. Albo has the exact same specialty as I do, and we share this practice, this very lovely practice, helping patients like all of you. And then Laura, my nurse who's on maternity leave, is amazing. She's the one that makes sure you have all of your durable medical equipment, that your prescriptions are up to date. And like with Mr. Floodberg's visit recently, correcting things in the record that might not apply to the patient. And so they make sure to keep me on track and accountable. So getting the right treatment, this is the last slide, ending with one of those beautiful San Diego sunsets. So getting the right treatments can improve quality of life in a significant way for Parkinson's disease patients. And I think what's really important is to have an open discussion with your urologist about the best option for your specific symptoms, because everyone is so, so different. Thank you so much for listening. It was so lovely to get to talk to all of you, and I'm gonna.
Thank you very much. That was excellent, very comprehensive.
All right, so let's see. Let's go. So are there any home treatments you'd recommend for me? Cranberry juice, Pedialyte. So cranberry has been studied a lot for recurrent bladder infections. You have to be careful with cranberry juice because cranberry juice can have a lot of sugar. And so I think that cranberry supplements are fine. It really depends on the patient. So I don't specifically know Jody's medical history, but some things to consider is some cranberry supplements can have oxalate, and oxalate can increase your risk of kidney stones. So you're definitely, if you are at risk for kidney stones, you do not want to take cranberry supplements that may have oxalate. D-mannose, which Dolores mentioned, D-mannose has a lot of evidence-based support to it. So that means that they have done studies that show that it is an excellent treatment for prevention of bladder infections. It's not going to prevent infections if your bladder's not working properly. But if your bladder is working okay, and what's happening is that your bladder is just predisposed to holding on to bacteria, which can happen. Sometimes if you get a big infection, the bacteria have these little bristles on them called pili, and sometimes they'll stick to the lining of your bladder, and even if you take antibiotics, they won't go away all the way. And some people, especially women after menopause, are going to have bacteria in their bladder normally. It's nothing bad about it. They just live there. And so for patients like that with normal bladder function, but who still are getting UTI symptoms, D-mannose can be a great option. I do not treat liver problems, and I am a very poor resource for the liver, unfortunately, because I focus so much on the kidney and bladder. So that I'm going to leave that there. I'm so sorry. I'm starting to have a problem urinating when I'm having tremors. I'm not relaxed, and the more that I try to relax, the worse it gets. Is this straining? It could be. So sometimes there can be an issue called pseudodyssynergia. And what happens is that as you are trying to contract your bladder, your pelvic floor is also contracting. And the more you try to strain and contract the bladder, the more the pelvic floor contracts, and it won't relax to let you empty. I think a pelvic exam would be a really great idea. And sometimes physical therapy can help with those symptoms. The other thing I wanted to mention, and I didn't want to get into the Parkinson's treatment specifically because I know a lot of you have really wonderful neurologists who know way more about this than I do, but often being on the right type of Parkinson's drug can really do wonders for your bladder symptoms. And it's important, that's why timing is important. So if you recently started a medication or recently you had a flare of your tremors, it's important to talk to your neurologist to make sure that you are optimized as far as treatments go, so that when you see the urologist, we really, can help with any residual symptoms that you might have. But that pseudo dyspnea or inability of the pelvic floor to relax is very common in Parkinson's patients who strain, and pelvic floor physical therapy can help with that sometimes. I think that an exam table and or walkway, as well as a waiting room chairs, need to have a bar and armrest to push off from. In your experience, this is stopping of an on-off experience usually happens suddenly or gradually over time. So perhaps that is talking about the urinary intermittency. That's great advice about the exam tables and the chairs. I'm gonna mention that to our clinic manager, because I don't think we are as equipped as we could be for patients like you. Starting and stopping of the urinary stream can be a symptom of that inability of the pelvic floor to relax. So that's intermittency is common. It can also be happening in patients who have enlarged prostates and other pelvic floor problems. And it doesn't usually happen suddenly. It usually happens over time. But again, everybody is different. How is interstitial cystitis diagnosed? So I can probably guarantee that if there are patients in this group right now who have bladder symptoms, that it's not interstitial cystitis. Interstitial cystitis is very rare, and it's a diagnosis of exclusion. The problem is that sometimes when we don't know what to do with a patient's symptoms, we will put them in a category that doesn't necessarily apply to them. And interstitial cystitis is one of those categories. I think that in order to reach a diagnosis of interstitial cystitis, you need to go on a pretty extensive journey with your urologist and exclude other problems first. But usually we diagnose it by excluding everything else.
What is it?
Interstitial cystitis is now more commonly known as bladder pain syndrome, and it is pain that's localized to the bladder. It's worse when the bladder is full. It's associated with a lot of urgency, and typically is treated by treating the bladder urgency and treating the pain. And so for the most part, the patients that I treat with Parkinson's related bladder symptoms don't have pain specifically. They may have pain related to the bladder not emptying, or they may have pain related to having an infection or having to strain to urinate. But interstitial cystitis is pain that exists with no reason. It's just the bladder fills and there's pain. And the bladder would function all right, except that there is this intense pain that causes urgency to urinate, and it only goes away when the patient empties. And sometimes even when the bladder is empty, there is still some residual pain. So that doesn't fit most of the patients that I see who may have these really bothersome bladder symptoms. Most of the time, they do have issues emptying your bladder or straining or other things that explain the pain. 64 ounces per day minimum. I'd say that's average for most patients. Some people who are very active may need to drink more. Some people who are not as active may get away with less. What's important is to, water is a great appetite suppressant. The more water you drink, if you're trying to lose weight, or if you have kidney stones, or you want to flush, you want to dilute the urine, water is a great option. Fluids are a great option. But remember, it's not just what you drink. If you eat vegetables and foods that have a lot of fluid in them, that counts for your daily water intake as well. So sometimes patients are just taking up too much water and the bladder can't handle it, especially patients who might be on a diuretic. So diuretic or water pills are medications that are given so that you can get some fluid off your body. And so those might exacerbate bladder symptoms. And so if you drink a lot of water along with that, you might be in for a rough time. Okay, I got a private one. So the person who wrote me a private message, this is something that what you've written me is something that any pelvic floor urologist can really help you with. And I think I can't speak more about it because I haven't treated you as a patient, but I think that's a perfect thing to come in and talk to the urologist about, even in a telemedicine visit to get started. What is the mechanism of the anticholinergic medications and why would you prescribe them? Okay, so the anticholinergic medications work by blocking the effects of acetylcholine in the bladder. And so every muscle has nerve attached to it that tells it what to do, that tells it to relax or to contract. And acetylcholine is the molecule that the nerve shoots out into the muscle to help it to contract. And so when you have an overactive bladder that's squeezing, it means that nerve is basically allowing that muscle to contract very frequently. So when we give something to block that nerve bladder communication, then the bladder will remain in storage and won't squeeze as much as it used to. So we would prescribe anticholinergic medications for patients who have storage problems, urgency, frequency, bladder control issues, nighttime urination. Those are the candidates that may receive an anticholinergic medication, or mirabegron, because mirabegron is a beta agonist, which means it's a medication that works on the beta receptors as opposed to the other receptors, and it has fewer side effects, but it works the same. It blocks that communication and then causes the muscle to relax. A PVR is a post-void residual urine volume, and that is the amount of urine that's left in your bladder after you have emptied it. And so we want PVRs, or post-void residual urines, to be low in our Parkinson's patients, because a high PVR means you either need a catheter or you are at risk for infections, for example, or you're at risk for leaking because your bladder's always kind of full. And so we want to keep those low. And so we will check those in patients that we think have some emptying issues. Are there effective medications that can help, and how long are they effective? There's a bunch. So if you go back on my talk, since it's recorded, there are medications that help your bladder hold urine for longer, the anticholinergic medications or mirabegron. There are medications that help you empty your bladder better, like tamsulosin or finasteride. There are medications that help with your erections. There are medications that help with your infections. There are medications that help women with the genital symptoms of urgency and frequency and pain with intercourse. There's a bunch of medications that urologists love to prescribe. And obviously there are antibiotics. Antibiotics are a last resort. I rarely prescribe preventive antibiotics, but some patients really do need them. And so that's another medication that I'll use. Do level exercises help strengthen pelvic floor? I don't know what level exercises are. So that's a great question. I'll research that. I am a big proponent of pelvic floor exercises and core work. And anything you can do to remain as fit as possible is great. But dedicated pelvic floor physical therapy and something called biofeedback, where the therapist will show you on a computer screen how well your pelvic floor muscles are working, that is incredibly useful for your bladder and bowel control. Is it true that the shaving procedure of the prostate can complicate things with Parkinson's disease patients because of the bladder as a muscle and the changing nature of Parkinson's disease on muscles? Yes, so that is true. That is why it is really important if that is a procedure that's being offered to you, that you've had an appropriate workup. So for example, that urodynamics procedure that I was talking about, that is extremely helpful for me in determining whether somebody is going to benefit from the from the prostate shaving procedure. So if you have a urodynamic study and it shows that your bladder doesn't hold very much and your bladder's overactive, then I'm not going to offer that surgery, because I know that when I do the shaving and open up the prostate area, you're going to leak more potentially and not be very happy. And so I try to really focus on the particular patient and what would benefit them. But as far as complicating things for your bladder health in the long run, I don't think that it will change how the Parkinson's will affect the bladder. And I think that you will try probably through the course of your disease different ways of managing the bladder. And you may get many years of really good urination control with some of these interventions for sure. Kegel exercise, yay. Okay, I think I got through all of them.
Excellent. Does anybody have another question that they'd like to ask before we end the evening? I'm going to unmute everybody right now. There we go. I've got it. Okay. So you all can see that information now. But I want to end by thanking Dr. Santiago Lastra again. This was excellent, very informative, and I really appreciate you taking your time, especially on a weekday.
Thank you.
Thank you.
Thank you.
You're welcome.
Thank you.
Thank you so much.
Thank you.
Thank you.
Thank you. Thank you.
All right.
Excellent.